Objectives for humility in cases is what one of my mentors and a lot of people joked about, is keep it simple, stupid. Things that you learn as you go, and what are times that retrospective scope really bites you in the rear. So, everybody talks about filters. Some of us love doing filters, complex filters. We've had a ton of different filters out there. Why are we so aggressive about removing them? We all know the data, and we have more patients coming in. There's a lot of complications from filters. We try to prevent some of them. We try to fix some of them. Also, unfortunately, there's a lot of visual aids that help patients get to your office. Why do we have to be careful? Luckily, it's nice to have friends who have complications that aren't yours, but they have some really wild ones sometimes. This is what can happen if you're not careful, and you don't want to see that ever. That's the kind of case that you don't want to see. So let's talk about the case that I can talk about, how I had to become humble. So a physician, i.e. me, decided to take on a complex filter early on. It's a 56-year-old male, DVTP, had a filter placed about 9 years ago at an outside hospital. Now, just remember, when you use that term outside hospital, to someone else, that may be you. So we love throwing that out there, but always be humbled by the fact that you may be that outside hospital. Of course, he had a filter placed for whatever reason, and then he moved, and this is what happens. We have no trackability of these filters and what happened, trauma, stroke, and then he comes to the wonderful state of Illinois, and he's been having vague abdominal pain, and also his family members have been seeing a lot of billboards. So he comes to your clinic and he says, I need this thing out. I've been told I have this metal contraption. It's causing my life of misery. You talk about the risks, the benefits, and you say, of course I can take this thing out, because that's your first answer. Then you go think about it and you plan. So you get some imaging, and this is the imaging. It's a wonderful Optese filter, placed exactly how you expect it to be, just crappily. So the approach on these filters, as you do more and more of these, usually are kind of a dual approach, top and bottom. Sometimes just bottom is fine. We always check venous ultrasound for the DVTs to make sure there's nothing going on in their legs, they're not symptomatic. You don't want to make them worse and leave something undertreated. So you bring them in for a case, and I use anesthesia for a lot of these cases, just because I don't want to hear the patient screaming or my partners to hear me screaming. So this initial venogram, and you see everything looks exactly how you want it to be when you start a case. Mostly groin axis on this one. I put some pictures to show you not really how I removed it, but what to do afterwards. But this was the approach on this one. I use a lot of laser for the ones that are really polyhedral, that are really scarred in. I end up using laser, sometimes all from below, like this one, as you see in the artistic pictures I've tried to create. And then, as you get excited when you do these cases, sometimes it works. And this picture, we do this case here, and it finally envelops the whole filter, and you're done. And I think this is learning lesson number one, is this is about the point when I get excited, we high five, we fist bump, we scream, patients intubated so they can't hear what we're saying. It's great. And so at that point, for me, when I get a filter out, me taking off the lead is literally 0.5 seconds later. But what you learn at that point is stop, think about things. And there's debate about whether you should do venograms afterwards. For simple ones, I don't think most of us do it anymore. You have to figure out what's complex. Complex should have been using a laser, doing all this stuff, because the fellow showed, should I do a venogram? I'm like, yeah, if you want to. And he did, and then that was what I got, which kind of sucks because he didn't look like that when I started. So then the question is, what do you do? He's not hypotensive, he's not crashing, but I can't leave it like that because now I have evidence, right? So then the next thing most of us will do is with balloon angioplasty. So that's what I did, used a bigger and bigger balloon. I think I went up to 18. And again, it was kind of like, great, we did our job, awesome. And the fellows do another venogram, I'm like, of course. And do the venogram, and looks like, oh, there's flow, it looks great, we're done. Fantastic. We'll send the patient home. We taught them how great this went, how cool we are as a filter removal service. This is amazing. Hopefully you guys all see this is not fantastic, but it's better than what I started with. So see the patient a few weeks later in clinic. And now they're saying, doc, my left leg's getting worse. It's swelling, a lot of pain, and you can tell symptomatically it is. So we get ultrasound. Didn't show any DVT, but questioned some waveform problems in the femoral veins. So maybe there's something proximal. So the next step is get a CT venogram. And because of my lack of being aggressive, this is what the patient had within a few weeks. And if you can see those pictures, it's completely clotted from the renals down. So now, from what was a cool high-five moment and being impatient, I ended up creating this, which is the venogram, when I brought the patient in the next day. Not very good. Definitely not what I left it with, but now it's worse. So now this patient undergoes I ended up doing thrombolysis, got across. It wasn't too difficult to get across. Brought back the next day, there's still a lot of clot. Brought it back the second day and find out what I really caused was a really bad disease of underlying scarring and stenosis. So you got to treat this. Ballooning alone is not working for this. So, it was a very recalcitrant lesion to ballooning. Bare metal stents, that's what we sometimes put. I wanted a short one. I ended up deciding I was going to put an aortic endocuff. And to protect the renal vein, protected the right renal vein. That was a lower one. Decided to protect it just so I know where it was. Put a 24 millimeter cuff there, ballooned it. You can see a waist there as well, which resolved. And then, of course, the picture looks much better there. Why is all this important? Because as you learn and as you do more and more, be humble, take your time, look at the pictures. There's a lot of complications you can cause. You can cause migrations, fractures. You can cause thrombosis. In my cases now, if I'm doing anything what I consider complex, I heparinize them. Even though you're pulling something that's scarred, and even though a 20-year-old filter, I still heparinize them. Flush the sheets. I have colleagues who've sent me, around the country who've sent IVC intussusceptions that they've caused. You don't want to create those things, so be careful. Don't pull the filter, sheath it. And then also friends have shared some arterial injuries too, so the preoperative imaging is very important. But for me, I think the humble pie is take your time, be thorough, don't be impatient, and learn. And a little bit of Midwest thank you.